Welcome to the Cardinal Minute with your host and chair of the University of Louisville Department of Medicine, Dr. Kim Williams.
Good morning. I'm Dr. Kim Allen Williams, chair of medicine here at University of Louisville, and it's my pleasure to introduce a Cardinal Minute. We had a wonderfully informative and integrative grand rounds this morning. It was entitled Primary Hyperaldosteronism, Teamwork and Talent, Win the Championship. We actually had three speakers, Dr. Krishnasamy, who you see here, Dr. Javid, who you see here, introduced by our division chief, Dr. Sri Mahsa, and we had a third speaker who had to run away and do his duty with the program that he's directing in radiology, Dr. Ohin Ba. But the two of you can cover for him if you can summarize, maybe 30 seconds apiece, the really intricate issues that you brought up this morning.
Sure. Thank you, Dr. Williams. Thanks for the opportunity. So our talk was primary hyperaldosteronism. It's a very common reason for endocrine hypertension for resistant hypertension patients. And the prevalence, as we know now, has quite a bit higher than we thought it was, almost 6% to up to 22 to 40%. So it's important to screen these patients early on in primary care. And lab assays are very important. Radiology is important, especially having a great interventional radiologist and great surgeons such as Dr. Javid and Dr. Ba are very important to have patients have the best outcome. It's a shared decision making with the patient about surgery and other treatments. And I will turn it over to Dr. Javid.
One thing that's essential is to know which of the adrenals is causing the problem and whether in fact it is unilateral disease. So Dr. Ba talked about adrenal venous sampling. It's very important to have a good ratio of aldosterone over cortisol from one side to the other to lateralize the disease. And then the treatment for unilateral primary hyperaldosteronism is adrenalectomy, which can be done either through open or minimally invasive techniques, either through anterior or posterior approaches. And it's very important to get the perioperative care right, which we do as a team. Make sure you're continuously monitoring the potassium, stopping potassium supplements, and potassium-sparing diuretics postoperatively, as well as monitoring the blood pressure.
And very importantly, screen these patients for Cushing's disease, or Cushing's also, which is excess cortisol secretion. That is very important to do in these adenomas. Thank you.
Well, this was an amazingly informative session. We are all treating, I'm convinced, people for hypertension who actually have excess of these hormones, and we need to be more aggressive in terms of our screening and then our management. So thank you very much. This has been a Cardinal Minute.